So yeah, I'm going to be talking about the esophagus. I'm going to kind of make some assumptions, so stop me if I'm wrong, because I don't want to, make some assumptions that would be incorrect about what you guys know and what you don't know, okay? So for this lecture, I'm going to be gearing it more towards surgery, because obviously surgery, so gearing it more towards surgery makes sense. Some of the anatomy stuff I'll kind of breeze over. Your chapter is actually pretty good. This is chapter 9, I believe this is in your book. It's actually really nice. I read it about an hour, and it hits a lot of the high points and stuff that I think would be important to know, and I'll try and highlight some of that stuff, okay? Alright, so let's get started. Okay, so some basic anatomy. These numbers also in this, I feel like I might have accidentally deleted some numbers, because it's not 1 centimeter in the neck, it's about 5. So I must have deleted some of my other numbers. But for the most part, esophagus has a couple of important points. There's a cervical portion, a thoracic portion, then an intra-abdominal portion. And that is important because it determines how you want to operate on the esophagus. So I like to think of it tracking down from your neck to your abdomen in a left, right, left direction. So in the neck, it's in the left. In your thoracic cage, it tends to be more on the right side. In your intra-abdominal portion, it's probably more on the left. So I think in my mind, when somebody's marching, like left, 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 right, left, that's how I think of the esophagus. Left, right, left, okay? So when you're operating on the neck, you want to more than likely make an incision in the left side of the neck, because you'll have an easier time getting to the esophagus. If you're operating on the esophagus in the chest, right thoracotomy is probably going to be your best bet. And then in the abdomen, really just a midline incision, but it's going to be more on the left, okay? All right, another important point about the esophagus. So it has the mucosa, the muscularis, submucosa. A really important thing that the esophagus does not have, and it plays a lot into its pathology, is it does not have a serosa. So that's really important to know, especially when you're suturing. So when you're suturing bowel, you want to get a bite of the serosa. That's the strength layer. The esophagus doesn't have that. So it makes it more challenging to stitch the esophagus. Okay. There's also an upper esophageal sphincter that's created by the cricopharyngeus muscle, essentially, and then a lower esophageal sphincter that's created by your diaphragm and the angle that your stomach takes, okay? That upper esophageal sphincter, like it says here, prevents air from entering. It prevents you from aspirating for the most part. The lower esophageal sphincter, it ideally should prevent reflux of those gastric contents and juices. And we'll talk more about that later. So I kind of broke the lecture down. This is more of an overview generally into kind of the symptoms and what you need to do for that. So for most of the time when you work up dysphagia, you go through a series of tests, and we'll talk about how you work up using imaging and less physical exam, because how in the world are you going to physically examine an esophagus? Heartburn will obviously cause you to head down a different set of diagnostic criteria, and then we'll talk about some emergencies, which are super fun. So, dysphagia. If anyone tells you that they're having difficulty swallowing, you should be concerned about them, because that generally means there is pathology going on. And it's hard to nail down, because dysphagia is such a nebulous symptom, right? Someone could say, like, oh, I'm having trouble swallowing, but, if that's a 20-year-old person, you might think, like, oh, maybe they're just not chewing their food enough or something like that. If it's an 80-year-old person, instantly think cancer. Really, anyone over 50, if they tell you something, it's probably cancer. But for these purposes, age plays a big role in that. And we'll kind of talk about your diagnostic tree. I like to think of things, and I'm a visual learner, so I think of things in kind of diagrams, and I like to diagram things in my head about how to work up a symptom. So you want to take a really good clinical history from this person. Is this dysphagia with solids? Is it with solids and liquids? Because those are really big distinctions. If someone's having problems with solid food, it could be there's a stricture or something like that. If they're having problems with liquids as well, there may be an underlying motility disorder or something like that. Also, the progressiveness and the intermittent, so the timing of the dysphagia is important too. If it's getting worse and worse and worse, probably something that's growing, like cancer. If it's something that happens now and again, you can't really put a finger on it, it's probably more likely a motility disturbance. Okay? And we'll talk about different motility disturbances, different cancers shortly. But some of these things for the esophagus, you kind of have to nail down more specifically using your diagnostic tools. So, how to investigate for dysphagia. Clinical history. That's really all you got when you're talking about the esophagus with someone and trying to work that up. So, physical exam, you can listen to your heart and lungs and those kinds of things. Really, it's about lymph nodes. You want to check for a certain lymph node. Does anyone know? It starts with a V. Yeah, Burchell's. Okay, sweet. So, that would be like the fancy buzzword lymph node that might have to do with esophageal cancer to some degree, or really chest pathology. But it's typically when you see a test question about esophageal pathology. So you can work it up with a chest X-ray. That's probably very non-specific, but you want to start broad and work your way down. Depending on what you think it is, you can get a barium swallow. You can get an upper endoscopy. So with a scope, you can do manometry to assess the function if you think it's a motility disorder, or if you think it's cancer, you probably need a CT in the chest, abdomen, pelvis, and maybe a PET scan as well. Okay. All right. So when you should be even more concerned about dysphagia, if they have weight loss, can anyone tell me what significant weight loss is, like a percentage?
10 or
Say it louder.
10%.
10%. If someone has lost 10% of their body weight without trying, that's the other key portion. If you say, oh, have you lost any weight recently? Well, yeah. Okay, are you concerned about that? Well, no, I've been trying to lose the weight. Okay, well, that doesn't count. If it's someone who's eating the same amount or they're not able to eat the same amount, taking the same calories, that's when you should be concerned that, if their weight loss is significant enough that they've lost 10% of their body weight. That's enough to actually consider you in the malnourished category. And it will be very important if that person needs an operation because malnourished patients do worse. So you want to make sure that they get good nutrition. So, other important things of delayed diagnosis for dysphagia, maybe they have, they present with a lung abscess, or maybe they present with some lung pathology, empyema, those kinds of things. You have to think like, okay, why is this 30-year-old person, why would they get an empyema, those kinds of things. It's normally patients that you don't, or maybe it's an older person that's having aspiration from their dysphagia. And then local extension of cancer, if they present with an aortic esophageal fistula, you might as well just kiss them goodbye because they're probably not going to make it to you. But if they could present with a tracheoesophageal fistula, it's probably much more likely. Aortic esophageal fistulas probably aren't going to make it. But tracheoesophageal fistulas do occur, and that's for pretty advanced cancer. But because of the proximity of the trachea and esophagus, they're right next to each other, and because the esophagus, again, doesn't have that serosal layer, it's not going to prevent that cancer from spreading. So it's going to spread more easily. So let's talk about some cases, because I feel like, we can talk about all this stuff all day. Y'all can read your chapter, but let's talk about some real life things. And so I'm going to need some audience participation. Okay. A barium swallow in this 80-year-old gentleman who had some difficulty swallowing. Have you all seen a barium swallow before? Okay, so you generally know what a normal one should look like. It should look straight down, like this is the barium, right? But there's something funny going on here. Like, what is this weird thing? Can anyone tell me? Shout it out. I hear a lot of mumbles.
Beckles diverticulum.
Diverticulum. Okay, there's a certain name for the diverticulum.
Is it Beckles?
Not Meckles. Meckles is the one that's kind of 2 feet from the ileocecal valve. That's Meckles.
Yeah.
Zenker's diverticulum. Great. Okay, so this is a Zenker's diverticulum. It typically, what are 2 reasons to treat this, or how do you treat this person? What would you do for them? Surgery. Good answer. Okay, great. Surgery is an option. When would you do surgery? Maybe. Like, I guess, what are some indications for surgery? Symptoms, yes. Okay, so I don't want to operate on somebody unless I need to operate on somebody, right? Because, A, this person's 80 years old. Do you think they're just 80 years old and healthy? Probably not. And they probably have some other comorbidities to take into account. So you want to really, if they need an operation, you want to make sure that you're giving them the right operation. So for a Zenker's diverticulum, it's a pharyngoesophageal diverticulum of the neck. That's like the fancy word, but the moniker is Zenker's. These are typically in older patients, so older than 50 years old, who present with some dysphagia, and maybe they'll have some recurrent pulmonary aspiration. They'll also present with halitosis, like, doc, I've been to the dentist 5 times. They can't figure out why I have such terrible bad breath. It's because you have a little pocket of food that is not digested in your neck that is disgusting. So that's probably why they have halitosis. Treatment is surgical if it's symptomatic and if it's large enough. So 3 centimeters is kind of the general rule, I would say. But like everything in medicine, nothing is black and white. So if somebody presents to me with a 1 centimeter Zenker's diverticulum, but they have terrible bad breath and they've had 2 episodes of aspiration pneumonia, yeah, I'm going to fix that because it's clearly causing those symptoms. But if somebody's got, a 2 centimeter Zenker's in their neck and they found it incidentally, then probably I'm going to be hard pressed to do that, especially if they're 80 years old. But typically, if they're about 3 centimeters, we will fix them. So to fix them, you can do it a couple different ways. If it's small enough, you can actually do it through the esophagus. Take a stapler, and you essentially just make a common channel between the diverticulum and the esophagus by bringing it back together. If it's too large that isn't going to be an option, you can enter the neck through which side? Left side, okay? And then you will just staple across the diverticulum and remove it. And it's a pretty simple operation, but again, you don't want to operate on somebody who doesn't need it and who won't do well, because it's still a big operation, right? Because what is scary about the esophagus is that it can, and those things can really present, they can present later, and they can cause sepsis, and then you're much worse off. So again, you want to make sure your surgical candidate is optimized. So you do, like this says, cricopharyngeal. Oh, so again, not only do you have to remove that diverticula or staple off the diverticula, but you have to fix the underlying problem, which is that this cricopharyngeus muscle is essentially your upper esophageal sphincter, and it's too tight. That's what's created this pulsion diverticulum. And so you have to do a myotomy, which is cut through the muscle essentially, and that will allow the sphincter to relax slightly and hopefully prevent these from happening again. Anyone have any questions about a Zenker's? Typically, a barium swallow esophagram is the best way to evaluate it. Ooh, no, but I would say for the buzzwords for Zenker's, it's older gentlemen with halitosis and aspiration pneumonia. That's typically how those common presentations for the test questions. Okay. Oh, actually, there's another little aspect of this Zenker's diverticulum that's commonly tested on. So this area of the upper esophageal sphincter is actually a weakness, and that's why the diverticulum forms. Not only is this a little bit too tight, but there's a weakness in the muscle, so it's kind of the perfect storm. And that area is called Killian's triangle. So that's another, I don't know if they would ever say Killian's triangle, but if they do, probably think Zenker's. All right. So we've got some more dysphagia. Okay, so we've categorized. So we categorized dysphagia. So here we go. Get that one out. Okay, so we got dysphagia, right? So solid. Typically, these Zenker's people won't have weight loss, right? They'll have halitosis. 33-year-old lady, difficulty swallowing solids and liquids. That is increasing, so progressive nature. But don't be fooled by that. 10-pound weight loss, regurgitation of undigested food. If you note this barium swallow, there might be a bird beak appearance, although it doesn't really show as well in the print, but there may be a bird beak appearance to this. So what is this x-ray, the barium swallow, demonstrating? Achalasia, okay. And how would you confirm that's achalasia? Right, what diagnostic test would you use? Manometry, good job. Because it's a motility disorder, right? And manometry measures the motion, essentially, of the esophagus. And how do you treat really bad achalasia? Yeah, say it like you mean it. Okay, surgery. So this is esophageal motility disorder. This one actually even has this little picture. It shows an epiphrenic diverticulum because of the problem. Achalasia. So you really, in order to work it up, you should probably rule out some other things. So that same story that she's telling you, 10-pound weight loss, it's progressive. What else could it be? Probably cancer, but she's kind of young. Although, sometimes cancer does affect young people, so you have to keep that, with that type of history, you have to keep that on your horizon. So you should probably do an EGD or an upper scope to really look and make sure that there isn't some giant funding mass that's causing this. So if it's not, then you can do an upper, barium swallow, look at that really dilated esophagus, the bird beak's appearance, and then manometry confirms it. So the preferred treatment is to do essentially another myotomy, so that lower esophageal sphincter gets tight. You want to open it up, cut through that, and allow the passage from the esophagus to go easier through to the stomach. What is an issue with that? What do we get with really dilated lower esophageal sphincters? GERD, right. So you essentially need to do some type of anti-reflux procedure along with a myotomy in order to protect this patient from problems with GERD, like Barrett's esophagus and all the other problems that come along with it. So that's called a fundoplication. It's essentially a wrap of the stomach around the esophagus. And it creates a new sphincter for all intents and purposes. And there's different kinds of wraps, but I don't think we need to go into that. Okay, you can also dilate the lower esophageal sphincter, but it's not, surgery is more definitive, and so people will need consistent dilations. Plus, there's a risk with dilation that you could perforate, and you don't want to do that. Okay, so achalasia, it's caused by lack of relaxation. There's some theories for why it happens, but I wouldn't really focus on that. I don't think it's very heavily tested. But essentially what happens is the lower esophageal fails to relax. And so it's motility disorder, and essentially you should do surgery for it. These are some manometric findings of it. So fun. And then these are some of the pressures that you would get from a manometric evaluation. So we have dysphagia with solids, which we kind of put down. Safer is an option. Dysphagia with liquids are weight loss typically. Well, we will have undigested. So some complications of achalasia. You can get increasing esophageal stretching. You can get epiphrenic diverticulum. It can cause you to lose weight. It can compress other structures in the chest. It can cause aspiration pneumonia. I guess it can also cause withdrawal and eating alone, although I don't know if that would stop me. So, okay. But the treatments of achalasia, like I said, pneumatic dilation, that can cause esophageal perforation. So 4% risk, that's a fairly high risk. All right, we've got another dysphagia case. I love these barium studies. So, 55-year-old guy, so over 50. Go ahead and frame that in your mind. 10-year history, so it's progressive, indigestion, heartburn, dysphagia to solid foods, and a 10-pound weight loss. And they just so happen to get this barium software for us. All right, what do we think it is? It is cancer. For sure, cancer. Okay, so he has, so this is the tricky thing. Probably solved. But they can also have, so if they don't have, no, they're just, cancer. Cancer's everywhere, really, is what this should show you. That really, it doesn't matter what type of symptom, it should always be in your possible diagnoses. So, a mid-esophageal stricture is pretty much cancer until proven otherwise. You want to get that history and physical and assess their other comorbidities, and then to work it up. So, how do you assess that stricture? You still probably need a tissue diagnosis, right? So, you need to do an EGD, so an upper scope. To evaluate that, you probably need to get a biopsy at that point, and then you can get something called an esophageal ultrasound, or it's EUS for short. And the nice thing about the esophagus is that when you ultrasound it, it shows the layers really nicely. I couldn't find a great picture of an esophageal ultrasound to show you, but it shows the layers really nicely. And the important thing about cancer is its depth of penetration, especially for the esophagus, because past a certain layer, the lymphatics live. And the important thing about cancer in the esophagus is lymphatic spread. And because it doesn't have that serosal layer to protect it, once it gets into the lymphatics, it's cat's out of the bag. So, esophageal ultrasounds are really nice to help determine not only the depth of penetration of the cancer, but also your next steps. Because certain esophageal cancers actually do better if they have neoadjuvant chemotherapy and radiation before surgery. So that helps just determine your treatment plan. So two main types, really this is 90% of esophageal cancer, is adenocarcinoma or squamous cell carcinoma. What type of person gets adenocarcinoma?
Heavy drinkers.
Heavy drinkers. Smoke. I would say that's probably more in the squamous cell, but smoking is a risk really for any cancer, so opt out. GERD, yeah, GERD because of the Barrett's, okay. Typically an older, overweight white gentleman. Well, actually, they won't be overweight because by the time you probably see them, still have loss of weight. But typically, it's a white gentleman. Whereas, who gets squamous cell carcinoma? So all these people, all these fun things right here. I guess demographically, who gets squamous cell? African Americans, yeah. African American males. So squamous cell carcinoma is typically an African American male. Adenocarcinoma is typically a Caucasian male. And all of these things can be risk factors for esophageal cancer. Obviously, smoking, risk factor for any cancer. But the difference between squamous cell cancer and adenocarcinoma is that squamous cell cancer is typically due to exposures to things, right? So if you eat a lot of really hot, spicy foods, if you burned your esophagus from like ingesting lye or something crazy like that, if you had, typically Asian diets, for whatever reason, have a lot of like nitrosamines in them, and from the cured meats and vegetables, and so they have a higher incidence of esophageal cancer. Also, if you have chronic iron deficiency, you can get cancer. If you're a young person and you've had a thymoma, or for whatever reason you've had, or lymphoma, or if you had radiation to your chest, that puts you at risk for squamous cell carcinoma, really because it's exposure. Adenocarcinoma is also exposure, but it's a different kind of exposure. Think of it in more of the GERD terms, because adenocarcinoma is typically that lower portion. Squamous cell carcinoma will be the mid-esophageal stricture that you'll see. So how to treat it, right? How do you treat esophageal cancer? I talked about it briefly, but
Cut it out.
humor me. Surgery. Thank you. Okay. Surgery. But some esophageal cancers, depending on your endoscopic ultrasound findings, will be treated with neoadjuvant chemotherapy and radiation. The scope of who gets treated for that and who does not is probably beyond this lecture, but that is an option. They can get neoadjuvant chemotherapy and radiation, and then they'll get surgery. So, you want to cut out that esophagus. It's super fun. These are great procedures. And there's a couple different ways to do it. So there's something called an Iger-Lewis, which is, I would say, probably like the old school way of doing it. I feel like a lot of the CT surgeons typically tend toward the Iger-Lewis. And it's a right thoracotomy and then lower abdominal incision. And so you cut out the bad portion of the esophagus and bring up your stomach, which is a nice handy conduit right there that you can create to become your new esophagus. And then you just stitch it to the old one. So like this little picture shows. Here's this nasty cancer right here, mid-esophagus, which is why you do a right thoracotomy. And then you cut that out, and then you bring up your stomach to create your new esophagus. So boom. You can also do a transhiatal approach, which is for cancers that maybe are a little bit lower on the esophagus, so maybe towards the GE junction, or something maybe that is a larger cancer. You need to take out more of the esophagus, and you need to create an anastomosis that's higher up in the neck. So you do a left neck approach to that for a transhiatal in order to cut out that diseased portion of the esophagus and then bring it up and do your anastomosis. You can also do both of these minimally invasive. So you can essentially use a robot, you can do it laparoscopically with a little camera, and do either of these procedures essentially in a minimally invasive fashion. Okay. All right, let's keep our head on the swivel. Esophageal emergencies. 6, 7-year-old guy comes in with some intermittent dysphagia, burning epigastric pain, retrosternal chest pain for 2 hours. He has been not able to tolerate anything. What else is going on? I think somebody said it. Oh, no, nobody said it yet. This is a bad picture of it. I don't know if y'all can even tell. Let me see if I can show y'all that a little bit better. Okay, this looks strange. Oh, hiatal hernia. Okay, there we go. What classification of hiatal hernia do you think this is? There's 4 classifications. What do you think it is? Type 4 probably, right? Yeah, it's bad. Like typically in your deductive powers of reasoning at this point in the game, the highest number is the worst one. So this looks like a stomach like in his chest, right? That's probably not a good sign. I don't know, you can't really see the gastric bubble as well in this, but in this one it looks like the gastric bubble is like kind of overlying his heart. So probably not where it should be. So hiatal hernia is a surgical emergency if it's a type 4. There's a couple of different types. I put them in here. Yes, okay. Go me. All right, I put the different types in here so you can see, and we'll talk about them. But for the type 4, that's essentially where the stomach is in the chest and it's becoming ischemic. So it's getting strangulated and it doesn't have blood supply, it's dying, and it's causing this person to become septic. Now the stomach has one of the best blood supplies in the entire body. It's got 4 different places. I mean, you can literally, when you do an esophagectomy and use the stomach as a conduit, you cut 3 of those arteries, so you only have 1 left, and the stomach still survives. So it's got great blood supply. So if the stomach is dying, you know it's for real. And things are bad because it's got such a great blood supply that it's necrotic. It needs to be removed. So if it's not viable, you need to take them emergently for a gastrectomy. You need to get it out of the chest and hopefully fix that. If it is viable, then you want to just try and bring it out of the chest and perform a hiatal hernia repair. But before you do any of that, you want to resuscitate them, make sure they're not septic and getting really, really sick. You can also try, if I've seen this in a couple of cases where we've done this, where you can insert a nasogastric tube, so an NG tube down to try and decompress the stomach to see if that helps with the decompression.
What if you have to do a gastrectomy, replace the stomach, or do you?
So it's typically your SOL for sure. It's not a great thing because your stomach does so much of your digestion, and it performs a lot of other things. So if you think about, the acid in our stomach isn't just for breaking food down; it's also protected for our immune system, right? So it performs a lot of different functions. And so if you lose your entire stomach, it's definitely not great. But there are options. But at this point, if you lose your entire stomach, you have to do an emergent gastrectomy. You would leave that patient in discontinuity, and you probably resuscitate them, get them stabilized, and then go back for a staged procedure. And then you would create a new stomach with a loop of small bowel. Yeah.
Back on that hyperlipid, about how, so you're stretching the stomach and you're connecting it out.
Mhm.
How do you reform like a lower esophageal sphincter down?
You can tighten the crura up a little bit. Luckily with gravity, some of that kind of helps because before, you've just got like this nice pouch of acid sitting there waiting to form all those things. Granted, you still have some of those same cells that are creating acid up in your chest now. So I would say,
Do they go like on a long-term PI or like?
yeah, they get a lot of medication management of their symptoms, and if they don't, then you can do a couple of different things to help mitigate the acid. So, great question. So, when someone becomes septic, there's a whole inflammatory cascade that occurs. And it can be from an infection, or it can be from, say, something is necrotic and sending a lot of mediators into your body that say, hey, something's not right. And so they kind of divert more resources to help fix that. But in essence, it makes you very sick when it initiates this whole inflammatory cascade because your stomach is dying. So short answer for a really big question. But sepsis is is a great topic, and there's tons of research on it that shows that it's actually there's a whole surviving sepsis guideline that you have to follow in order to be, giving your patients the best treatment. We can get more into that shortly. So hiatal hernias, you can NG tube decompress them. That's unsuccessful, but you probably need to go to the OR to decompress it. So here's some different types. So type 1 is essentially like a sliding hernia. It goes up, goes down. It's not a big deal. People may notice it, they might not. A type 2, maybe you got a little more stomach up there, but it might be symptomatic. It's surprising how many people we see that don't even know that they have type 3. But a lot of times it's still incidental. Type 3, you've definitely got, this is probably a bad picture of it. That's actually a pretty good picture. So your lower esophageal sphincter is above your diaphragm. Your GE junction is above your diaphragm at your sphincter. And there's also stomach above the diaphragm as well. So type 1, it's just the GE junction. Type 2, it's a part of the stomach that's above your diaphragm. Type 3 is the GE junction and a part of your stomach. And then type 4 is the whole Monty. So to treat them, you want to try, like I said, you want to optimize them as much as possible. You want to make them prove that they need an operation. So for the different types, you can try medical therapy. And a lot of times that's successful. That takes care of a lot of people. And there's many, many different medical therapies for it. There's PPIs, there's H2 blockers, those kinds of things. So, and for a lot of people that helps. But for the people that it doesn't help, you want to operate on them. So to operate on them. Type 3 is definitely, type 4 probably need an operation. Type 2s you could probably argue, but those are fairly rare. So I would say 3 and 4 most likely get an operation if they fail medical treatment. In order to do an operation for a hiatal hernia, you want to reduce the hernia, right? You want to remove that hernia sac. But then you want to prevent it from happening again, right? So you can secure it with mesh. You can make that hole between the chest cavity and the abdomen smaller with mesh. And you can put this in combination with an anti-reflux procedure, like the wraps that we talked about. So taking a part of your stomach and wrapping it around the esophagus. And that will help prevent it from sliding up and down. Okay, another case. Ooh, we didn't talk about, let's see. Well, we'll keep rolling. I don't want to. So, 50-year-old lady, nocturnal regurgitation. She has got sour taste in her mouth, heartburn for 5 years. She wants an operation. What is the most helpful thing in deciding whether to perform anti-reflux surgery? Is it medical therapy? Is it her incompetent lower esophageal sphincter? Is it the reflux-associated mucosal injury? Increased exposure to gastric juices? All the above. Okay, sweet. Good job, guys. So GERD, we kind of talked about GERD already. Gastric juices. It's because your lower esophageal sphincter is incompetent. Normal pressures are 15 to 30 millimeters of mercury. People that have reflux probably have it less than 6. Really less than 10 is probably present. And again, like we talked about, you can get it after treatment for achalasia with pneumatic dilation. You can get it with tissue diseases like scleroderma. So symptoms we kind of talked about, you get that burning type of feeling and chest pain, but you can also get coughing, you can get aspiration pneumonia, you can also get dental caries because of the gastric acid. So to investigate it, you want to make sure if they do have a hiatal hernia that that's something you can treat for it, right? So it kind of helps guide your therapy. You could do an EGD because what if that person has Barrett's esophagus in their lower esophagus? And you want to make sure that you're monitoring it, and if there's changes that would indicate that it might be cancerous, you probably don't want to just tuck it into the stomach and wrap your stomach around it when you do that procedure, right? So you want to rule out these other things before you fix the underlying problem. Okay, what's the best test for GERD? Acid perfusion, barium, 24-hour pH, EGD, manometry. Yeah, 24-hour pH. Good job. That's the kind of the gold standard. This slide's super wordy, so this just kind of goes through some of the other tests that we've already talked about. In the interest of time, I won't do that. I trust you all can read. But 24-hour pH monitoring is the best test. So, medical therapy, antacids, H2 blockers, PPIs, and then surgical therapy like we talked about. After you've ruled out that there's nothing else going on in the lower esophagus, it's healthy, you can treat their hiatal hernia if they have it, and then do an anti-reflux procedure. Okay, complications we kind of already talked about, aspiration pneumonia, those kinds of things. But Barrett's is a real problem for GERD, and that's a nice segue into our next little case. 45-year-old guy, recurrent heartburn, simple chest pain. So you do an endoscopy to evaluate it in your workup, and you see this like salmon, I believe, is the buzzword for that. Salmon streaking, and you can definitely see a change in the mucosa. So it's columnar to squamous, right? So you take some biopsies, and you're like, holy moly, it is Barrett's epithelium. So that is essentially when your esophagus is mostly lined with squamous cells, right? Your stomach is mostly lined with columnar cells. That columnar epithelium then starts creeping up, and it changes in your lower esophagus because of its exposure to acid. So you want to monitor this closely because this Barrett's epithelium can transform to adenocarcinoma. So surveillance is really important. And high-grade dysplasia is legitimate, and they probably need treatment for their high-grade dysplasia because it can develop into adenocarcinoma. So let's say they don't receive treatment, they do their own thing, and then they get this nastiness, which is most likely adenocarcinoma of the esophagus if you're using your deductive powers of reasoning. So it's that malignant transformation. You want to get a biopsy, you want to get a CT scan, and you want to get a PET, so that pretty light up scan that shows you where the cancer is and really where the glucose is being taken up at the most elevated rate. You want to get an EUS, that esophageal ultrasound, to evaluate the depth and penetration of this. And then, just like we talked about, depending on the findings of that, we'll either let you proceed to an esophagectomy or maybe you need neoadjuvant chemotherapy. So adenocarcinoma is increasing, and it may, this GERD may be related, but it may not necessarily be due to acid reflux. But you should get a biopsy. That's essential. Here. Okay, I think this is towards the end, so don't worry, I'm close to finishing. 45-year-old guy, he had a large meal, and he's a drinker. Comes into the ER with really, really bad chest pain, especially on the left side after retching. That's like the buzzword, retching, for a long time. His pulse is elevated, so he's tachycardic. He might be on the bridge of hypotensive, and his temperature is elevated. So I would say he has developed a surge response, may even bordering on sepsis. What do you think would be the most likely cause of his illness, especially since we're talking about esophageal things? Thanks. Good job, guys. Okay, so perforation. This is bad, especially if they're maybe an alcoholic, may not be in the best shape, because they can be emergencies, and you need to either treat them immediately to surgery, or you need to resuscitate them and then take them to surgery in order to evacuate the cause of the sepsis. And the reason it is because, we have bacteria all throughout our GI tract. That bacteria should not go out to outside of our GI tract, like in our neck. Where's the most common perforation? Is it the cervical esophagus, thoracic esophagus, abdominal esophagus?
Cervical.
Cervical. Good job. You guys are so smart. Okay, cervical esophagus. And what do you think is the most common cause of perforation?
Warm body.
Say what?
Stretching. Warm body.
No. Iatrogenic. There we go. What does iatrogenic mean? Yeah, we cause it, right? It's somebody who's doing an upper scope and they punch right through that really thin wall in Killian's triangle and create a perforation. Those people are less likely to get septic and need a surgical, be a surgical emergency, but they're someone that you need to watch very carefully. But people most likely, I think 60% of people, the book says, will have iatrogenic perforations, and that's because we cause them, so be careful. Right, but you want to treat them with antibiotics specifically because, the things that are in your esophagus and your GI tract do not typically live in your neck. Okay, this is kind of a crazy case. Dr. Smith kept this one up here, and I figured I would too. So, anterior superior mediastinum, fluctuating weakness in her arms and legs, slurring of speech. She probably had some regurgitation of solid and liquid food. What are some important nervous structures that run right near your esophagus? There's there we go. I don't know if anybody else said it, but vagus, your vagus nerve. So what might this sit in? All right, I won't keep you in suspense any longer. Okay, so she had pseudoachalasia due to cancer in her gastric cardia. And the reason why she was having these other symptoms of weakness in her arms and legs, slurring of her speech, those kinds of things, it was because of the grew into her herbs. So these are some pearls for esophageal surgery that I feel like I've taken over the years. These are commonly asked questions, especially by surgeons, I feel like, when you're operating in this area. So what are the 4 birds of the thoracic cage? So the thoracic duct, okay? Also know the tract of the thoracic duct. So what is the thoracic duct? Lymphatic structure, right. So the path of the thoracic duct is really important because when you're operating on the esophagus, it runs right near it. And it has kind of a weird path that like crosses over at T5 and then shoots up to your subclavian vein. But you can easily injure it and you don't want to do that. So first bird of the thoracic cage, thoracic duct, or duct. That's the only duct of the cage, by the way. Your esophagus vein, that runs right there. And if you really want to buy yourself some time, because you can't think of the other ones, you can say hemiesophagus as well. Your vagus nerve. So your vagus, you have 2 vagus. Which one's anterior, which one's posterior? If you look at the next 2. Left is anterior. Left is anterior, so right is posterior. And that's important because they kind of rotate once they get to the abdomen. So make sure you know that. And then your esophagus. So your thoracic duct, your esophagus vein, your vagus nerve, and your esophagus. So 3 geeks and a duct for the 4 birds of the thoracic cage. Your vagus nerve. It's important to know the tract of the vagus nerve. The vagus does a lot. It provides so much activity for all of the structures essentially in your upper abdomen and your chest. So vagus nerve is not left behind. So your right is actually the behind one. Left is anterior. And then your diaphragm apertures. So come enter the abdomen. The vena cava is first. It's a T8. So if you can just remember the cava is a T8, you're good to go. Because then just 2 more is the esophagus and 2 more is the aorta. So CEA, 8, 10, 12. Does anyone have any questions?
It's 2:30 now. Take a 20-minute break. Come back at 2:50. We'll do a couple presentations at that time.